What's up, guys? Dr. Nessim here. In this video, we're going to be reacting to Brigham Buhler, the founder of Ways to Well, speaking with Joe Rogan on his podcast about the state of the health insurance industry and all the bureaucratic involvement that is potentially harmful to patients, as well as other cool topics like using generative AI in patient care, patient choice, and how overall the system affects the way that physicians practice. I thought it was a very interesting conversation. Some things I agreed with, some things I didn't. Let me know what you think, and let's get into the video.
Huberman gets into all that, academia. There's tons of studies on this. So, and all, I think the main reason it's not adopted more often is they're just in the insurance model, right? They use the tool that's in their tool belt. And if that's not a tool in my tool belt, then I'm not going to talk about it, and I don't have time to do it. And that's where I see large language models and an evolving market allowing patients to get that education on their own. They don't have to wait to talk to a doctor, right? I will have a team of academics right there at your fingertips, proactively analyzing everything about you. And I would tell you, I talked about predictive, proactive, personalized, all that. Another one would be private. Private. You do not want this data in the hands of insurance companies. Listen to what Gary Brecka was telling you. He worked for the big insurance companies. He worked to assess your all-cause mortality risk and the risk profile to the insurance company, right? And so if let's just say,
So first off, I don't know if you've seen my last Gary Brecka video. Gary Brecka is a little bit in the pseudoscience realm, talks about some of the things he says are accurate, but a lot isn't, and talks about being able to predict the exact time that someone dies. Well, the way Brigham just explained it is a lot better. They're assessing all-cause mortality risk for big patient populations. It seems like this clip jumps into the middle of the podcast where they're talking about being able to use AI, generative AI, to give tailored recommendations to patients. Now, will medicine eventually trend this way? I think it definitely will. A lot of health tech companies are competing right now to make different versions of AI that can service patients. With that said, there's always going to be drawbacks to every new technology. And I think that if you're not having experts, like true experts, the thing is it's also hard to qualify who an expert is, and also being able to communicate well with patients and explain information. I think you may have a little bit of a problem if an AI is generating these explanations and reports about all of their data. So people in the future will be getting, and already do technically get, some healthcare and results interpreted with AI. Radiologists are already using AI to help them doing reads and things like this. But you don't want to, on the mass, have an AI that's treating a bunch of patients, at least not right now. I don't think that's good for general public health. And more importantly, if one of these AIs that's speaking to patients does have a mistake in it, does get bad data into it, then it becomes a very big ethical dilemma. Who's at fault? And also, just in general, it is a nice part about being a physician, that human-to-human interaction. I don't think that's really ever going to go away.
in a miracle world, all of a sudden, Blue Cross Blue Shield rolls out a large language model to streamline your experience, and they want to tie into your wearables. The last person you want digging through your underwear drawer is the insurance company, because they're going to use it to limit your care, to limit what they cover, and to kick you off a plan, right? They're going to know when the chronic disease is coming, and they're going to charge you when they know they can monetize you. And then as soon as you reach a state where they can't, and that's the dangerous side of these large language models, and that's the dangerous side of the tool. And so a sword in the right hands is, one thing, and a sword in the wrong hands is a whole nother thing.
Yeah, I agree with that. He's talking about insurance companies being able to use this generative AI. Never think that insurance companies are out for your best interest. They are there to maximize profits. They are beholden to their shareholders. And so a lot of these insurance companies, they will deny medications, even if it might be helpful, if they feel like there's a cheaper alternative that could be used. And they make it, even if they're not necessarily the evidence, let me rephrase. They don't always follow strictly the evidence, Sometimes they follow what's better for their bottom line. Now, there has to be evidence-based guidelines to try and back whatever they're saying, but the amount of times that a doctor will order an MRI that gets denied by the insurance company, if a clinician, let's say a sports medicine specialist, wants to get an MRI on a patient, I would trust their clinical judgment more than the insurance company and the doctors that, or NPs or whoever that they hire to deny those claims that aren't actually seeing the patient. And so, yes, there's got to be checks and balances, but the way the system is right now, you're basically just letting insurance companies dictate what care people get. Because, for example, if I'm in a clinic and I want to do visco supplementation for knee osteoarthritis, but the insurance company only covers steroid injections, guess what option the patient's going to be choosing, and what I'm going to probably end up promoting more to the patient because their insurance doesn't cover it. And so this is a topic I'm definitely passionate about, looking for solutions. I think that there needs to be more competition and true capitalism within healthcare to help drive down costs with, of course, a social safety net. But right now, we don't have that. We have phony competition because like 3 or 4 major insurance companies really own everything in the space. And that includes even some of the pharmacies and pharmacy benefit managers.
I wonder if they are trying to do that. I wonder if these insurance companies are trying to.
They're for sure going to roll that out. Yeah, if they're not already. And that's the problem. Like when you have an insurance-based model, and that's where I would tell you, maintain the car outside of the system, right?
And the insurance-based large language models are going to ensure that you stay on these treatments because that's where they're profitable.
Correct. So there's the insurance company, and then we broke this down last time. Then there's the pharmacy benefit manager. Pharmacy benefit managers are a middleman between the insurance companies and Big Pharma. Okay, and they were put in place to negotiate the price of pharmaceutical drugs for the average American because so many drugs were coming into the marketplace. The government couldn't get to and decipher what drugs make sense, what drugs don't make sense, what should we cover, what should we not cover. So they allowed pharmacy benefit managers to do that. Within a decade, the big insurance companies went out and acquired pharmacy benefit managers. Within a decade from that date, the pharmacy benefit managers began to negotiate rebates to themselves, not discounts to the patient. Okay? So, yeah, that's where I was trying to go with this. When I talked about $244 million in fraud in the state of Ohio, how? Where's the fraud?
Yeah, that really is a good simplified summary of how the system works. I mean, it's really crazy that there wasn't an antitrust breakup of insurance companies or pharma companies buying up the pharmacy benefit managers, because pharmacy benefit managers now just play a middleman role and increase the costs of most of the medicines you're getting. That's why you see these other companies like Mark Cuban's Cost Plus Drugs companies cutting out the middleman and basically able to show you exactly what it costs them to create the drug, what their markup is, and then you pay that. Now, when there's patents on certain drugs, it becomes much harder. But the second a drug is generic, it should really drive the cost down. But what's crazy is even if you have a generic drug, if you're on a Blue Cross Blue Shield plan, for example, and they've negotiated rates for themselves, essentially, there might be some generic drug that costs hundreds of dollars. Like I think, what was it? There was some medicine in my intern year we weren't going to basically prescribe to a patient. Let me pull up my tweet about this, actually. I tweeted about it at the time. And I think Mark Cuban actually retweeted it, which was cool. Let's see. There we go. Okay. I'll read you the tweet. We almost didn't prescribe a patient cinacalcet today because it can cost about $800 for 30 pills. And then I mentioned Cost Plus Drugs. We looked into it. $11 for the patient to get it through Cost Plus Drugs. So this patient's insurance was going to charge almost $800, but we could get it for $11. Now, we should, and this is actually also a topic I'm passionate about. I don't think we should disqualify patients from certain medicines. We should still offer every option, even if it's expensive. Just give the facts, give the treatment available, let them try to know the cost the best you can. Sometimes it's hard because it's their insurance that you have to then figure out what everything's going to cost. But you should never say, oh, it's going to be too expensive, so we shouldn't offer that treatment at all. With that said, it seemed like the attending I was working with at the time, they were very discouraged about being able to offer this medicine just because they knew most patients were not going to pay for it. And then we were able to look up, if you cut out the middleman and you just mark that drug up a small percentage on what it costs to me, $11 it was costing to get this patient the medicine.
And the answer is the margins are made in the mystery. The more confusing the insurance companies can make it and the more convoluted they can make it, the more profits they can make. They have only a handful of levers they can pull to make money. So let's go over that. They can raise your copay. They can raise your deductible. They can raise your out-of-pocket expense. That's one lever. They can drive down the price of a drug that they buy at a wholesale price point. They can mark up the coverage of your care for your employer. Okay? And then they tier price. The pharmacy benefit manager gives a tier pricing. That tier pricing is not based on what drug is best for you. It is based on what drug is best for their financials. And so they prioritize drugs in a tier pricing under the misnomer to the American people that a tier 1 drug is the best drug and a tier 4 drug is not as good, right? But the truth is a tier 4 drug is not as profitable because there's a lesser rebate. And so...
So just to give the benefit of the doubt, or just to play devil's advocate, I do agree this is probably true sometimes. It's not always true. I mean, at least they're supposed to be recommending based on what is the most effective. And you can say also cost-effective treatment, but only if it's cost-effective and studies have shown there's no statistically or clinical difference between those two tiers of medicines. With that said, research is changing rapidly, and sometimes if it's for the benefit of the insurance company, they may wait an extra year to say that they agree with that research, or 2 years to say they need more studies to come out before they move this tier 4 into a tier 1 drug that may be more expensive that they would have to cover, but maybe actually showing better outcomes.
So let's go back to the insulin example. The average price of this insulin is $381 is what the Senate Finance Committee found. $381 on, I can't remember if it's Sanofi, I think, was their price. Out of that, the pharmaceutical company got less than $40. So that remaining $200-something stayed at the pharmacy benefit manager. Okay, pharmacy benefit managers are making billions upon billions of dollars a year. They decide what gets covered, what goes on your insurance plan, what your copay is, what your deductible is, and they can move any lever at any time. So examples, let's go back to GLP-1s, right? The weight loss diabetes medications. Those are showing up on insurance plans as tier 4 with a really high price tag. Well, you look at that and you go, man, wouldn't insurance companies want to get rid of that because it's costing them a lot? No, because they're showing that the price of a GLP-1 is $1,300. They never paid $1,300. They paid a fraction of that. But then they go to the patient and they say, hey, this is a tier 4 drug. You have a 50% copay on this drug, $500. Okay, so they made their money there. They made their money off the rebate from Big Pharma. Then
so
they
the
come
patient pays more than they actually are paying for the drug.
Correct. That is what happens on most drugs.
And that's
that is true. And it is kind of messed up. You pay, I mean, obviously if you're getting so much more benefit than you're paying to the insurance company, that's a problem. But most of the time you're paying a ton. I mean, their families are paying $20,000 a year, maybe even more for the family for health insurance. And then they're getting medicines at not the right cost of what it should cost them. I'm not saying there shouldn't be markup. Like, people should make money, but not off of like this convoluted system that ends up really hurting the patient. And when you have these insurance companies making absolute billions of dollars in what sometimes seems like a pretty shady system.
Why I built a compounding pharmacy. Yeah. And but even if they don't, let's say it's a drug that you think is covered. Okay. Maybe the pharmacy benefit manager got it wrong. A drug entered the market. They didn't know it was going to be a blockbuster. They miscalculated how this was going to play out. They have lever after lever they can pull. Okay, high margin drugs, they've gone out and bought pharmacies. So they own mail order pharmacies. And so what they'll do, like when I owned a pharmacy, Blue Cross Blue Shield, they literally said they owed me over $1 million. For 1 month of shipping out drugs. I'd already shipped all the drugs to their patient. I'd already done everything. They come in and say, yeah, we're not going to pay you. We don't think you collected the copays or deductibles. Okay, we did. Here's all the records. I can show you how soon can you get an auditor out. We want to cooperate. Like, we're a small company. We need this money. It's 3 months before we can get to you. Okay, and then they begin to make it so hard for you to survive in their insurance model. And then you'll be sitting there and a couple months later, knock on the door. Hey, man, heard it's tough out there for these small pharmacies. You know, we're looking to acquire pharmacies just like you, right? They've gobbled up the lifeblood of America. They've put all these small pharmacies out of business. They now own most of these big juggernaut pharmacies. So even if CVS says, we only made $10 off that prescription, what did the pharmacy benefit manager make?
That's a good point, because it's deceiving, because that may all be owned by the same company.
Okay, or what is the pharmacy, your mail order pharmacy, making? Lever after lever after lever. Then the last part of it is, my buddy who has MS, his MS treatment, I think, is $14,000 a month. We just met. I have 260 something employees across both organizations. We met with the insurance company. They're raising our rates because they claim they paid $14,000 a month for his drug, right? He had a huge out-of-pocket burden on that drug, but was happy because he thought, well, hey, man, it was going to be 14 and I only had to pay X. And then they never paid the 14 because they negotiated a rebate on the back end. And then they turn around and they mark up my insurance plan for all my employees every year, year after year. It is a profit-driven system, not a patient outcome-driven system.
Boom. That's a good line. Profit-driven system, not a patient outcome-driven system. And it should be a patient outcome-driven system where better patient outcomes incentivize better profits. But it's very hard to align those incentives. And there have been places that try to do it, but every time you try to do it, there's always drawbacks to every plan, because it also depends, how do you measure those outcomes, right? So for example, if you're measuring those outcomes by hospital readmission rates within 30 days, then hospitals really only care about you not coming back in 30 days. But what about the long term? Like, are you okay in 60, 90, 120 days? I'm not saying they don't, that's all they care about. But the point is, people and organizations go and act in whatever way the incentive structure has them act. And so the best way to fix a system is to fix the incentive structures. But that's very hard to do when you have massive organizations who have the ear of government officials, and they have millions and millions and billions of dollars to lobby. And so it becomes very hard. That's why I believe Ways to Well doesn't take insurance. There's other like direct primary care practices that are popping up. There's more doctors that are going out of network. But that's also hard, because then you have to have patients who are paying you out of network rates. And if they come to you, their insurance will only, let's say, cover 20, 30%. And then the patient has to cover the rest, versus going to someone that's in network. With that said, sometimes things are actually cheaper than you may think. For example, getting medicine through a cost plus drugs pharmacy, or some version of that, versus getting it through your insurance plan, which actually at times, ironically, is more expensive.
And so that's all I'm trying to hammer home with patients. When you say, why don't you take insurance? Because insurance is the crux of the problem. You cannot operate in that ecosystem and provide quality care. You can't. Everything's controlled. Everything's dictated. It's terrible.
And most people have no understanding or awareness of this. So there's no real push to fix this system. There's no real push to regulate and analyze all of these problems and what's the downstream effect of these problems.
Yeah, and I even hear clinicians talk. A lot of clinicians don't know. Like, a lot of clinicians don't even know about pharmacy benefit managers.
That's true. They really don't teach this stuff in medical school or in residency. We just prescribe. I'll be honest, like, a lot of times you just prescribe the medicine and you hope it's getting covered by the insurance. Sometimes you have to do prior auth. But having this complex knowledge as a physician with all the other things you have to do, it is very challenging. I'm not saying we shouldn't know. I'm just saying that it's an unfortunate case. I definitely think like classes in med school on these topics would be helpful. And then we do, like at my med school, we did do some stuff, but it's such a complicated, I mean, to know this type of information, you really need to have like years of studying it almost.
The only reason I know is because I've been in every aspect of this business, and then I would get into it and I go, oh God, that's why that was happening. Okay, now I get it. Now I get the magic trick. I understand what you're doing here, how you're moving and shifting profits and monetizing disease states. So think about this. If I can monetize your diabetes, why would I cure or prevent your diabetes? Right? And
okay, this is one of the first places I'll probably disagree a little bit. I think this is a little bit cynical. That's the word I was looking for. Cynical. I do think that in large, like, to even if you take insurance out of it, like doctors are still working to manage someone's diabetes and help them the best they can to cure their diabetes and get people. Let's say you're type 2, we give medicines for it, health, lifestyle and diet, losing weight. All of these things will decrease your hemoglobin A1C, and you can actually get out of being a type 2 diabetic and become maybe pre-diabetic, even better. I'm not saying this happens frequently, but doctors aren't doing anything, I'd say, different right now with the treatments that they are giving based on the current system that we have.
And I know if I'm a bigwig at United or Cigna, that you're going to switch jobs in 3 years. And by the time that diabetes leads to metabolic disease and a cascade effect that puts you in a hospital that costs me more money, you're somebody else's problem.
That's true. So in terms of the way insurance works is most people have employer-based insurance and people switch jobs. And so there's less emphasis on preventative care as it should be because not everyone stays with the same insurance plan throughout their entire life. If they did, then let's do the weight loss medicines, the GLP-1 agonists as an example. Those might be expensive to cover, but if you have someone on there and they're going to be on your plan for 20, 30 years, maybe even longer, and downstream, down the line, 10, 15 years later, they don't have that heart attack, and they don't get diabetic neuropathy and don't end up having vascular issues and get an amputation, things like that, well, then it would actually make sense to cover the more expensive medicine early on. But because people jump around on insurances and because it's employer-based insurance, a lot of times it's not built into the incentive structure of the insurance company.
Or if I can stall it long enough, you're the federal government's problem. And so every aspect of healthcare is focused on that quarter, on that time frame. Another terrible example of surgery, and this is honest to God. I talked to my buddy who's a president at an orthopedic company. He told me he was sitting down with a surgery center about joints. And there's a new joint that they have, and it's more expensive, but the efficacy data of the long-term benefits on it astronomically outperform the other joint that this hospital system was using. He sat down with the CEO of the hospital and he said, here's the data, 5 years out, here's what we're seeing, da-da-da-da-da. The CEO said, I don't give a shit what happens 5 years out. Swear to God, this is a call I had yesterday. He said he looked me in the eye, Brigham, and he said, if you told me that this joint will last at least 90 days and it's cheaper, that's all I care about.
Oh my
because
God.
all of their data and records and accountability are only on the first 90 days. Once you're out of that 90 day and you've done your little review and all that, you're off again and you're no longer a monetizable patient. And so too, when we talk about
So I'm going to hope, I guess two things could be true. It could be not accurately translated. It could be it was said in jest, but he doesn't really mean it. But if you're just looking at numbers, like this is where this example ties back to incentive structures. And so will the hospital pay for those more expensive? If there's significant benefit, I would like to think they would in terms of clinical outcomes over a long period of time. But if it's not enough and it's more expensive, and it might be, but these are cheaper and still has the same results after 90 days, and that's what they get evaluated on, that's the problem right there.
Primary cares and what's happened. The same thing with pharmacies where they've been gobbled up by insurance companies, if they're in the insurance model, is the same thing that happened with primary care practices. The day of a primary care being independent and a free thinker is over. They're employed by hospital systems. Major conglomerates have gone out and bought up the primary care practice.
Okay, that doesn't necessarily mean the doctor themselves isn't a free thinker, though. I've seen, like, one of the things I see when I got to medical school, and residency, the biggest surprise I probably had was the level of discrepancy there could be between individual physicians. I always thought, like, when I was younger, you go to the doctor, like, more or less you're getting the same treatment no matter what. That's really not the case. There are some clinicians that are outstanding, evidence-based, really do everything to the T, critically think, like, go the extra mile. And then there are some that, if you go to the complete other end of the spectrum, really don't care at all and are practicing bad medicine. And then there are doctors that are trying their best, maybe not getting everything right, but still doing a good job. It really spans the spectrum is the point I'm making. And so I would say, even if you're employed by certain institutions, there's still going to be critical thinkers. With that said, sometimes it makes it harder because let's say you're to practice in the way you fully want, because let's say that institution, I'm just going to go back to this as an example because it's easy for me, like knee arthritis. Let's say that institution doesn't do as much visco supplementation. That's when you're putting like hyaluronic acid in the knees for osteoarthritis. Well, you're probably not going to be doing as much if your institution doesn't push for it or cover it. But if your institution does, then you will. And so, and that goes for like many different specialties. That may not be the best example because that's something that most institutions will do. But the point I'm making is that the way you practice can sometimes, as a physician, be affected by the institution that you're at and the insurance that a patient has, which is unfortunate. You should really, in an ideal world, we would be practicing whatever is the best for the patient at all times.
Why? Because now they have the patient population. If I can get you at the primary care level, then I can control the referral of where that primary care sends you as we profiteer off your disease state. Okay, so you go to a primary care.
Okay, I'm just going to stop here because, like, yes, some people are making a profit. It's not as cynical as that because he too has a company that makes money based off providing health to people. I get the point he's trying to make, but I wouldn't take it that far. And I know where he's going. He's about to say like primary care will refer within the same institution, which is true. Generally, if you're at this big academic institution or big like Kaiser in California, like they're going to refer within their own network. And if you're a patient and you want to get second and third opinions, I encourage that. You kind of have to look elsewhere yourself because they're not going to give you the direct referral usually outside of their own network.
Let's just walk through the same example I gave earlier, a methylfolate test. They never run that test, right? There's genetics. The methylfolate test tells me my genetics, but there's epigenetics. The choices I make every day impact which genes turn on and which genes turn off. If nobody ever has a conversation with me in my 30s about my hormone levels, about getting into the sun, about eating right, and you push me towards chronic disease because you wrote me a prescription to treat a symptom, and now I go through this system and I get cancer, that primary care is going to refer me to an oncologist.
Okay. First off, most primary cares will talk about those things. They're going to talk about lifestyle, diet. That's what you do as a primary care physician. They will prescribe medicines to help treat chronic disease. Of course they will, but we shouldn't diminish any of the work that primary care physicians are doing. And most of them are trying to do their absolute best and are doing a good job.
And that oncologist is part of that same system, right?
The test he mentioned, it's not like that's not a standard of care test. It's not saying I'm not saying it's something you can't get and wouldn't. If people want to know about certain polymorphism for how well their body methylates, this is like a hot topic in this more regenerative, not even regenerative medicine world, like the longevity world, I would say. You can get it, but that's not like a standard of care that primary physicians need to be offering.
And most people don't know this. 65% of an oncologist's income comes from chemotherapy, from the markup they're making off your chemotherapy. 65%. And I attached that link, Jamie, too.
Yeah, I'm going to have to look up the data for that. So most people, like most oncologists that are working for academic institutions or I promise you, they are not prescribing certain chemo medicines thinking, oh, I'm making a profit off of this. They get salaried half the time, and then they have RVUs for procedures and things like that, but they are absolutely not making decisions of your chemomedicine treatments because that is what is making up their salary. And like if I were to use Brigham as an example, like he has ways to wells. He offers stem cell injections. A large percentage of his income is based off stem cell injections. Should we now not believe that the stem cell injections are helping? So that claim is, I don't. I think that's trying to paint the oncologist in a negative light. Now, there's actually a good debate on certain chemos and whether or not they're actually effective or cost effective. But there's no malice in, at least from the physician and when they are prescribing these medicines. And if you have cancer and your doctor is recommending a certain chemo medicine or radiation therapy, you're always welcome to get a second opinion, but they probably have good intentions, and I would generally trust the recommendation. Of course, it should be a partnership. You should be well informed as the patient. They should explain risk benefits of everything to you. I'm just saying, don't be scared of chemotherapy if you're happen to be watching this and it's the recommendation from your doctor and you have cancer, because the way this is framed, I feel like, is alluding to that.
Where it talks about this. So all I'm getting at is Russell Brand said this, and he was spot on. Another guy who's not a clinician but understood what's going on here. If we make things about profits and quarterly earnings and big business and not patient outcomes, don't be shocked when we get phenomenal quarterly earnings and piss poor patient outcomes.
65%.
65. And I attached the link just so we'd have it.
So they have a financial incentive.
So this is an article where they were trying to, the insurance companies were trying to incentivize them to use a generic in this instance, because this is one of those issues where there's no rebate and no way for the insurance company to monetize it. But it breaks down how much money these guys, 65% of an oncologist's income comes from that.
I also need to look into that. Like, was this a study done and or was this an article focusing on something specific and now a broad claim is being made from it? Let's see. I'll look it up after the video and maybe I'll add it to the show notes. But that claim is a little bit shaky in my opinion.
Wow, this is incredible.
And so I say all this again because I don't think that a clinician's to blame. I don't think that they're just operating in the system that they're given. They're playing with the playing field that's been set before them and the rules of the game that have been set before them.
That's a fair way to end it. With that said, a overwhelming majority of physicians have patients' best interests at heart. Yes, there's burned out physicians. Yes, this system has a lot of flaws, and I would love to help to change it. And it's going to be a slow process. And I'm not saying physicians should always take insurance. You're more than welcome to practice out of network and things like that. But there's a very interesting overall discussion and perspective on the state of the insurance industry, healthcare itself, and I think not a lot of people are as informed about it. So I had fun watching it, learning from it, and reacting. What do you think? Did I say something that didn't make sense to you? Something that was wrong? Leave it in the comments below. Don't forget to subscribe, and I'll see you in the next video.